Welcome to part 2, in which we contrast upslip and downslip. And again, I'm Jerry Hesch, a physical therapist and founder of the Hesch method of treating the SI joint / pelvis. Here's a picture of the sacrotuberous ligament, part of it connecting, of course, with the long dorsal sacroiliac ligament. Now, if you can imagine that on the left side you had a true upslip, okay, by definition, the left sacrotuberous ligament, the origin on the sacrum and coccyx goes obliquely a 30 to 45 degree angle and inserts onto the ischial tuberosity. Those would actually be closer together. Therefore, with an upslip, when you palpate the sacrotuberous ligament on that side, it will be softer, easier to depress, more elastic, easier to strum like a guitar string. Now the opposite, if you have a downslip, sacrum stays where it is, ilium comes inferiorly, this ligament will be very taut. Now here's the right one, and they removed the left. Would be much more taut. So when you try and depress it, it would lose its elasticity and honestly would feel like a bone. Well, there is no bone in this area. It's all soft tissue only. And so this sacrotuberous ligament would feel very, very hard, and that's what would happen with a downslip. Now, in addition to those methods of testing for upslip, downslip, again, you want to gather a little bit more information, and you want to know how this structure moves. And the way that we do that is we perform a spring test. Now, a spring test is not simply taking up the slack in a structure and then thrusting it, okay? That is how spring tests are typically taught. However, we modified that a little bit and found that we get a lot more information. And basically what we do, if I'm going to push this ilium inferiorly, is you make appropriate contact, and then you push with about 20 pounds of force, that's an average, more or less, depending on body type, until you take up the slack. And if you can focus right in there, Amanda, you can see that in this anatomical model, right there, I've taken up the slack and it stopped moving. So we've gotten to where the ligaments are now tight and the surrounding soft tissue is tight. We've taken up the elastic element, and at least theoretically, we are now going to provoke movement in the joint itself if movement is available. Now, with a downslip is an unstable pattern. And with a downslip, if I applied an additional 20 pounds of force, it would feel sloppy. It would feel mushy. And when I let go of the spring test, I still feel it. I let it spring into my hand. It would be very delayed. Okay? Now, with the downslip, a vertical spring test could also be tested. But the most important spring test is to go inferiorly. You could alternately go superiorly, and you would find that it would not go superiorly. There's a disorientation of the articular surfaces, and it could not go up. Now, there is a belief that with downslip, people just walk and it pushes it back up, but that really is untrue, at least to my understanding. And if you look at how the forces would go through the hip, it does not parallel the SI joint. It does not make sense that that would push the ilium up at any phase of the gait cycle. So we can debate that later. I'm not going to do that here. Now, for an upslip, for a true upslip, the ilium will have moved superiorly. So you will find that the posterior iliac shelf will be higher on this side, as will the PSIS, as will the ischial tuberosity. Now, with a true upslip, there's not a lot of vertical motion available, and it gets stuck at end range. That means you cannot spring it inferiorly, okay? It also means you cannot spring it superiorly. So when it's stuck in both directions, that is in fact an upslip. So the way that spring test is done, of course, pretend the client is prone. You would contact the lower portion of the ischial tuberosity. So you come underneath it, palpate below it, put the heel of your hand, push in a pure vertically direction. I'm going to switch models. So let's just treat this client as lying prone, and you would hook this and you would push with 20 pounds. It's not enough to move the rest of the body. Take up the slack if you can, spring it with an additional 20 pounds and allow the recoil to move your hand. So you're not letting go and going to zero, you're feeling the recoil. Now if I try this and I can't take up the slack, I know that I won't be able to spring it, but I have to use 20 pounds at least. Same thing, if I come up here and I take up the slack and I'm pushing in an inferior direction and I cannot take up the slack, I can add another 20 pounds of force. And we've measured that with scales and such in a fairly large population. And 20 to 40 pounds is a good estimate, a little bit less than the average female, but you can tell their body type and you can tell by feel when you take up the slack. So you take up the slack, or you can't. And you attempt the spring test, and if it's stuck in both directions, that is an upslip, a true upslip. Recall that with a downslip, you actually had some inferior mobility. So that is how a spring test can be applied to help you make a discernment of whether you have an upslip or a downslip. And I'm going to show you very quickly that we do have some flexible pelvic models that are ideal for practicing the various spring tests. And then we do have a small flexible one, and you can make an inquiry if those interest you. But what I would like to do right now, I think I've covered that part of these questions thoroughly. I would like to show you, time permitting, a video of an orthopedic surgeon who did some spring tests under fluoroscopy. His name is Thomas Bernard, and I believe that he practices in Atlanta. So we're going to stop here and we'll set up the video. Or stop. No, leave it. We're good. This was presented at the World Conference on Low Back Pain and its relation to the sacroiliac joint. And I believe that it was the 1992 Congress, which was in San Diego, and there was a repeat Congress in San Diego in '95. So it's been too long for me to remember, but it's referenced in the back of my workbook. And here you can see some motion occurring with that test in the SI joint. It's a video fluoroscopy. Now, of course, this is not a quantified evaluation. It's not measuring exactly how much motion is occurring. I submit to you that this is a very, very relevant demonstration. Nonetheless, it changed my entire perspective, and it became much more important that motion occurs through the structure than that motion occurs only within that structure. So it gave me a more global perspective. This video fluoroscopy is just over 2 minutes. So this would be the one you would do to evaluate for an upslip, and you would also do it to evaluate downslip. You can see part of his hand on the top of that, and that is it. Thank you. This is all that I can address with respect to these inquiries. In terms of treatment, I would actually treat it a little bit differently. I would treat it with the viscoelastic model, which is described elsewhere. We have two websites, www.heschmanualtherapy.com and heschmethod.com, and we have a distance learning program, and this is all I can say. Thank you. Please feel free to contact me if you have any questions. Thank you very much.